Good afternoon, everyone. Thank you so much for joining our virtual fireside chat. My name is Yaz. I'm excited to have Marcio from Praxis here. We have a full hour for this session. I know many of you are buried into earnings as this morning has been very, very busy for all of you. So I'm very grateful that everybody is able to join the fireside chat. And again, housekeeping rule is the same. So if you have any questions during this fireside chat, just utilize the Q&A box at the bottom of your Zoom and submit your question. I'll make sure to direct them to Marcio. Marcio, I think that maybe a good place to start off is sort of big picture, right? Before Monday's readout, we had the phase 1 data, and we weren't really sure by looking at the phase 1 data how vormatrigine would differentiate. Now we've learned quite a bit around its differentiation with this data set, so versus other therapies. So maybe walk us through what have you learned from the study?
Mhm.
And then question 2, also broad, what are some of the, I guess, things and considerations that you think the street has not appreciated into the data? And then we'll go really deep into the Radiant.
Sounds good. And I appreciate the invites first and foremost. And I always knew you live in the future. Yes, but you just confirmed. I think it's still morning on every time zone in the US.
Yes.
So good morning, everyone, not afternoon. So like if you take a step back, right, just as you said, a big picture of vormatrigine, what we are seeing, and I guess what we continue to see, carrying from great preclinical evidence to the PPR, to obviously all the safety and pharmacology and everything preclinical and clinical we've seen so far, is a drug that really can help patients with epilepsy a lot. And that was a promise until this week. Uh, and I think that's quite important. And maybe I'm not sure if I say underappreciated. I'm not sure if there is a need for appreciation as much of just people paying attention to what everything that's going on there on a world with very low and narrow attention span. It's when we had the PPR data last year, there was a lot of quote unquote pressure to like say, what does that mean? What does that mean? Right? You might recall we had some conversations, and we always, I would say rightly so, said what we know is this drug's in the brain. What we know is that's doing something for the epileptogenic formation that's happening there. We're measuring this. We're happy. We can't really translate to what's going to happen when we treat a focal onset seizure patient or generalized patient. A lot of like asks and pressure to try to translate. And I think we stayed pretty serious about it because we really couldn't, right? That's where the science is, despite the fact we had like 100% of the patients responding on that study. You fast forward to the place we are today, the data set we really wanted to have for multiple reasons as a first data set, of course, is Radiant, where we treated a significant number of patients, refractory, difficult to treat. One could even argue the most difficult patients to treat, right? The ones that actually gravitates towards studies like this. And it is undeniable how active the drug is, right? So transforming from a promise to a drug is a big deal, in my view. And that's kind of what we have this week. Now, we can go one by one, as I'm sure you're going to go into the aspects of that and why we are so excited about it. But in summary, when we look into the actual markets, right, look into not people like you and I or all the investors on this call, but like the real people living with epilepsy, it is very, very clear the issue out there. Number one, it is a massive market. Uh, so the idea that, and as we go very quickly to this zero-sum game, that well, there is a drug or two drugs or three drugs that are going to solve the problem of epilepsy, I think is a little bit delusional and far-fetched, right? Now, are there situations where you're like looking to the market and we slice that differently and you say there are like bigger winners throughout those slices? I think so, and we can talk a lot about that. But when you have 3 million, and I'm rounding down patients, and over 60% of them cannot tolerate or respond to the current treatment, I think we all would agree that there's a huge space here. Like look into the history of epilepsy drug launches that were safe and efficacious, and they all did really well. Now imagine one with the profile of vormatrigine, and then you can imagine what it can really do. Uh, and I think that that's why we're so excited, right? We went through somewhat of a promise. Of course, we were excited about it, to a lot more than a promise today with helping really real patients with focal seizures reduce their seizures or resolve their seizures, as you've seen on a good number of them.
Thank you, Marcia. Let's now dig really deep into many elements of Radiant, and then we'll talk about Power One and Power Two and Three. So let's start like just confirm the trial size. So Radiant, when you reported out, you said you had 61 patients as of July 25th, and the total is going to be targeting 75.
Right.
So, and you're going to read that out in 4Q. So
Right.
is that difference of 14 patients then generalized that we're going to get at? Or are we going to get in the next 4Q a combination of
Yeah.
both?
No, a mix. I would say we're pushing very hard for the generalized patients to be the majority of them. Of course, that is the data set that is missing here for us to complement. But there are still, I think we're very transparent on the disclosure, right? Talking about the patients that were screened, meaning they finished the screening. There are, of course, patients in screening, and some of them are generalized, some of them are focal, smaller number in focal. And the patients that we dose for more than a week, that's the 61, and between that and like multiple weeks. And then the patients had completed, and that was the data set promised to the street, and we have here to discuss that was the 37. It is actually, in a sense, it's a place of privilege, right? To be with so many patients, number one, interested, and two, being able to recruit in such a fast study. Give us a lot of safety data, gives us a lot of understanding on these patients, a lot of different background therapies and things like that. So we feel for the stage of the program, running like multiple phase 3s on the next several months, it is a very good thing to have so much depth of data to learn what we can learn. And we learn a fair bit about, number one, how to recruit these patients, how to follow up, and like we had incredible compliance to the seizure diary, for example, with something super important, but it's never a given, compliance to drug, and everything else, management of AEs, as I'm sure we're going to talk about. And it's a large number. This is not like 10, 15 patients as we had before. So that allows us to make a lot of extrapolations as well.
So I guess it's fair to say that when we get data in 4Q, it's going to include obviously generalized patients that we have not seen, and maybe few additional focal epilepsy patients that maybe had not finished 8 weeks at the time of the data cut of July 25th.
Correct. Correct.
Okay.
You'll make a clarification here. All the difference between 37 and 61 are all focal. We only do focal numbers there. And you probably can expect a few more, 2 or 3 more or something like that, focal, and then the rest generalized.
Okay. All right. Very helpful. Now I would like to spend some time on sort of walking through sort of exposure related to efficacy, safety, and discontinuation, because I think that's going to become really important as we think about this translation to the Power One study and Power Two. So I guess the first question is, can you confirm that the PK in patients was comparable in healthy volunteers?
Yeah, beautiful thing. I love the fact you asked this because I don't think we discussed this enough. The number one thing you wanted to learn here, right, was exposure and then safety and then effectiveness. The exposure, there were a number of questions we wanted answered, and I think we answered all of them so far. So the first one is exactly what you just asked. Is the PK profile, outputs of PK comparable to our volunteers or not? We know that patients with epilepsy in general, but focal onset seizures particularly, have a lot of other drugs, a lot of comorbid conditions. Things just happen, right, on these patients. They're not, quote unquote, healthy as the healthy volunteers are on a study. And it's incredibly comparable. So we're very, very happy with that. It is very reliable as well in terms of predicting. So You want to first know, like, can I compare with what I have for our volunteers? But the
Mhm.
second is, can I extrapolate from that since we have.
Before you go there is, I want to like kind of like I walk through each of them step by step. Okay, so
All
we
right.
learned PK between healthy volunteers and patients was the same. Check. Second check is, can you confirm that the 30 mg dose group was linear in AUC and Cmax?
Yeah, there was just like we had before, right? So we were expecting, of course, we didn't have multiple doses here, but it was comparable to what we've seen with the previous multiple ascending dose for 30.
Mhm.
And the exposure spread was similar as well, which makes us believe that the way the drug is, the
Mhm.
accumulation was similar, steady state reaching was similar, that there is nothing to believe here that the dynamic that you've seen before of linearity wouldn't be kept on this.
Okay. Next question is, would you say that the level of variability is comparable?
Yes, fairly comparable. Yeah, surprisingly, right? You would expect a lot more variable here. So that is another very good metric.
Okay. So I guess, for example, so if you previously disclosed that the coefficient of variable for 45 milligrams in healthy volunteers was 29%, you saw something very similar in focal epilepsy. So
Correct.
check. Okay, perfect. Now, I know that now with this data, you guys going to do, and you do extensive modeling, right? And think about sort of additional data over time. I guess the question that I want to know is like, almost any exploratory analysis, you could look at quartile based on AUCs, and then you look at the sort of seizure reduction, right? So you can actually think about treatment response to AUC based on
Mhm.
quartiles. So would you say it's fair to assume that the top quartile could actually generate 75% reduction? Like,
Oh,
since it is linear and you can divide it up, am I getting over myself as you think about that? Because that's going to be important when we think about the 40 mg dose group in Power
I
One.
couldn't agree more that that's quite important. Let me take a step back,
Yes.
right? So we collected intense PK on day one and on the end of study on day 56, and then trough levels throughout the study. So a number of predictions here, right? We use a PopPK model. It's being developed based on the health volunteer data, and then we check with this and so on and so forth, as you know well. So we ask a number of questions to that, like how is the not only AUC as you just mentioned, but to jump into AUC, you have to believe it's an AUC-based phenomena. It can be both AUC and Cmax or other things based, and I think there's a combination of both here. And I can tell you that that is a dose response or concentration response because it's really not dose here. The dose was just one. For both Cmax and AUC in terms of response. If you split that in four similar groups, as you just mentioned, right, in quartiles, yes, the top group is better and better numerically. Now, I always have to put the caveat, right? This is not that small of a study, but it's still, we got to be careful once we start breaking down things into smaller and smaller groups. The error definitely expands on a situation like that. Uh, but it gave us confidence for two reasons, like without maybe getting off my skis and saying, oh, that's going to be a 7 or an 8 or a 6 handle, whatever it is on that number. I think there are a couple parameters we wanted to make sure were true for that dose of 40 to be selected for power 2. So the first one is, yeah, that number had to be bigger, right? Meaning there is a reason to go there from an efficacy perspective. But that alone wouldn't allow us to go there, right? Because if all the side effects were concentrated there, or there was like a very direct relationship, then we would have to pause as well and saying, then we go there and the safety profile. But it's not the case, right? So I think we have a lot more of a response in terms of efficacy than we have on safety from a concentration standpoint, possibly because there's a lot of other things influencing safety here, and efficacy is really being influenced by the drug. So
Okay.
that might be why. This is amazing. This is almost like what you always want, right? You're giving more drug, you get more effect, but you're not having any worse safety profile. And that was the base on why we believe that 40 would be adequate here in power two. So yeah, when you combine a time-based effect, which we haven't
Yeah.
discussed, right? So we're discussing concentration like independent of time, but you have both concentration
Yeah.
and time. So it's a longer period of time. We also see like a deepening over time of effect. And going to 40, it would not be proper or correct for me
Hmm.
to say I don't expect a larger effect there because it wouldn't be true. So
Okay.
that is what we are thinking.
Marcio, maybe, so you noted too, right? The PK and the exposure had no effect on safety. You just noted that. Did it have an impact on discontinuation rates?
Yeah, it did not. Yeah.
Okay. So,
I don't know if you
and
want me to check the box or to expand.
yes, no, I think no, because we have so many questions and I want to kind of like team up in a way just as we think about it. So now that we're on the topic of discontinuation, let's just kind of close the loop as investors have asked a couple things. One is when you think about the discontinuation rates that you reported of 23%, that 23% was based on the 61 that you got at the beginning of the study. Is that correct?
That's correct.
Okay. Okay. Second question was there a time by which these discontinuation occurred?
Uh,
And what was that time
yeah, the
cadence?
vast majority of those patients discontinue in the first 3 weeks of treatment, with a little bit more towards the first and second week there. It's interesting, yes, right? Like we are maybe to a fault, like we're saying, like we're not happy with this. And it's not that we're not happy because the data is bad. It's normally like people are not happy because it's bad. Like it's actually very good from a discontinuation rate. Well, ideally you wouldn't have any, but you gotta understand, and we said this before, right? And I think that's why I find a little bit ironic that people are bringing it up as we haven't talked about this before. Uh, the setup of the study like attracts patients that are a little bit more severe, they're a little bit more refractory, but also they know their own drug, so they are more likely to attribute like anything to drug and potentially discontinue. I think what we failed to maybe act a little bit faster was when we inform the physicians, right, the PIs, and we train them and we reinforce the training with them. And I would say it's never enough. And maybe if I'm going to call failure, maybe a small failure is like to just reinforce even further. Because what I end up seeing was it was probably more related to certain sites than to the overall effects. Now we can't definitively say that, right? We'll keep running the studies. But if the experience on Power One is of any information right now, and it's
Yeah.
blinded, and of course, you got to be careful with blinded data in general, but the overall rate is significantly smaller. And I think we can overlap the fact that certain sites that had a little bit more discontinuation are not on Power One, and they were the ones influencing. If it was a generalizable phenomena, then we would be seeing like across the board in other sites as well. So either the training or that we obviously always reinforce, or the fact that there was really a little bit more PI driven to some extent, and I'm not throwing anyone under the bus, right? No one
Yeah.
wants patients to discontinue. It just sometimes happens. That might have unduly influenced the rates here.
Marcio, so since you noted that the power discontinuation rates on a blinded basis is less than what you saw in Radiant, can you remind us what you have said around what your assumptions were in discontinuation rates?
Yeah. So if you go back and look into the way we power this study, uh, all the data we had to work with was historical data,
Mhm.
right? And you go through historical data on both drug and placebo throughout, like I'm gonna call modern anti-seizure medication
Mhm.
drugs. And you have like Extol, and you have like the C013 and 017 from Xcopri, Neurocrine study for their 1.6, actually Xenon's original molecule, but Neurocrine developed like 1.6 blocker and so on. And you look into all of that data, which is publicly available. And it is always tends to be around 20%. You go across the board and you look into that, and it's like, yes, a little bit higher for the most part, but I think we can say that the central tendency there is around probably 25, but then we're like 20%. So that was the assumption to begin with, that we are on the actual protocol and how we determine the power for that study. Of course, we believe that like with more intense management, meaning like really just like talking to patients, right? I talked to investigators this morning. I talk to investigators all the time, and they're like, it's common sense to just call patients and check in on them in general, let alone in clinical studies. Sometimes it's just not done. That we would, and we still believe that in the future, we're going to have like lower rates than that. But that's how it was defined. In a sense, almost every study in every disease has a base rate, and the base rate for epilepsy is around 20%.
Okay, thank you, Marcio. Let's pause and take a couple clarification questions since we are on discontinuation. So I guess first question from our client is asking around what discontinuation and dose reduction rates were in the 30% of patients who were on background cenobamate patients versus the 70% that was not.
Yeah.
So could you maybe talk about that?
Yeah, absolutely. So if you look into those 30% or so, a little bit higher in the ongoing basis, cenobamate rates, right? Those, I think the way it was portrayed to me, I don't like talking about patients like this, but I'm going to paraphrase. It's like the worst of the worst, right? It's like the patients we threw everything at them. In general, it was no different than the overall. And if we go and we look into two aspects of that, which is quite impressive in our view. One is to ask, and I don't know what you hear from doctors, but when you go and pull the market and we ask which dose of cenobamate are you using, right? The most common number back and what claims data to the extent that triangulation tokenization works here is around 200 milligrams per day. Those patients were around 300 plus per day, right? So they are way more prone to have all sorts of side effects and discontinuations, things like that. So it basically to say it's not a hedge or anything like that. It's basically to say those patients were really on the top of what they could tolerate, the break of that. And the discontinuation was not any different, right, on this, which is, to me, is quite positive.
I guess the one positive thing is that when we had done channel checks is that a lot of docs don't really get comfortable to prescribe more than 200 mgs. So the fact that you just told me like majority of them being on 300 really like highlights that these are really experienced docs that are part of the study, because a normal doc would not feel comfortable to go there. So like maybe another nuance here, I guess, just as you're talking through this, is sort of the integrity of the study and the quality of the sites.
Oh, no doubt.
One more thing I want to drill down to is, and you said it in passing as we were just having the conversation, that the discontinuation rates were not like that, they could have been run by few sites. Could you drill down? Because, I mean, did you get a chance to look at, like what the distribution was? Because that's another maybe aspect to keep in mind.
Yeah, no, we did. I think it's one of the first things we do on an ongoing basis, right? Our clinical operations team is quite on top of that and having conversations. And they also happen to be some of the first ones to have patients. So no fault of their own, in a sense. They are learning a little bit about this. And but there was somewhat of a concentration, I would say. As numbers grow, we should keep asking is this concentration real, right? As everything else we do. And I think now we can fairly confidently say, yeah, there was somewhat of a concentration as we have significant number of patients dosed across the program, which translates into a good thing, right? Because it is very hard when you have no idea where it's coming from. But it becomes why, again, not necessarily a positive in overall to have anyone discontinue, but when you know where it's coming from, like there are actions you can take. And I think the primary action here is just like a reminder, like consenting of the patient, reminding of what the side effect. There's always going to be a random effects, right? So on what happens, but I think we're trying to control the non-random effects like this one you just describes.
Okay. Another question that a lot of people are asking us, since majority of the discontinuations occurred between week 1 and week 3, how is that impacting the efficacy? Like, how did you calculate total seizure reduction for the ones that you missed the data for,
Yeah.
both for baseline and end of treatment?
Yeah, absolutely. So the most kosher way to calculate seizure rates, right, in epilepsy studies, and maybe a little reminder there as well. I know it's obvious, but so we use an electronic diary where patients have to confirm their seizures or lack thereof every single day. So we have like that, and whether or not they took the drug as well, they confirm every single day on the diary. So you have a number of days and a number of seizures, right? So you can create a rates there. And that is pretty much how everyone does. Small variations here and there on the fringes. It does not really change the overall number at the ends. So you would imagine that if a patient who discontinued earlier, they tend to be, number one, less opportunity to respond, like as response depends over time. And the second is they sometimes are not the best responders because like that's one of the factors on discontinuation. So that's kind of a double negative in a sense. And the data are used, right? If that was the question behind the question, like their data is entirely used. So one could hypothesize, while that's the proper way to analyze it, that it reduced the effects, right? So when you reduce the number, you increase the effects, hypothetically speaking.
Okay. Another few quick, how many total patients discontinued out of that 37 that you looked at?
Yeah, so we're gonna put the exact like numbers and
Yeah.
like numbers at risk at the IC post in like
Yeah.
3 weeks or so. But it was similar in terms of the rates of discontinuation between the 37 and the remaining that are in the 6 to 1. Numerically, a little bit more on the first 37.
Okay. And thank you. That's helpful. And is it, I guess, fair to say that at the end, final analysis, 32 out of the 37 finished like 8 weeks of treatment then?
That would be a little bit better rate, right? So
Yeah.
then it would make the other ones to be worse.
Okay. Yeah.
So no,
Okay.
it's a little bit smaller. Yeah.
Okay. Got it. Okay. And then Margie, would love to talk about, I mean, I think big picture here is if you look at other focal epilepsy studies, and I think it's in the appendix of your slide deck, comparing it to Xenon and Summit studies, they were between 23 to 27. So it's not really shocking that you ended up at 23. So that's like, I think we get that. So I appreciate you answering a lot of colors around it. I guess another question that has come up is when you look at one of the things is the total rate, the reduction of total seizure reduction was 56%. But if you look at the time curve and you look at week 1 through week 8, you really see actually consistency. And if you did calculate your seizure reduction from baseline to week 8, you would have ended up with 70%. And I think even in week 5, you had 100% seizure reduction. So maybe kind of help us think about, now that you learned this about your drug and Power One is going to be 8 weeks, like what do you predict to see by going longer and plus sort of, and then remind us, what is the calculation of seizure reduction, I guess, too, in Power One versus Radiant?
Yeah, absolutely. So we do see, right, and I mentioned that on the PK discussion we had, both concentration response, which because there's some accumulation, there's a time response to it as well, but a time-dependent response. Can we disentangle? No. So they're both, and we can look into both. Maybe, again, too honest there on saying we really can't disentangle. But we do see over time patients get better, I think the most obvious way to look into this is the spacing of the seizures, right? They get longer and longer in between, and eventually, I think we all wish they go to zero on the majority of the patients. So just by linearity alone, you would expect that you give 4 more weeks. That's the case for Power 1, it's the case for Power 2 as well, and that the number would continue to reduce. It wouldn't be far-fetched if you actually look into our experience with relutrigine and EMBOLD, right? That every time we checked, and relutrigine is a great data set to look into that because there's no discontinuation basically, right? So we are really looking to the same cohort of patients without much of a survivor bias, which sometimes the biggest problem on longitudinal cohorts is that you're really not looking to the same number on the long run, or even a similar number on the long run. So I think when you take that learning here as well, and the learning we have for vermetrogene, yes, it should. I'll go back to, do we need it before people start creating expectations, and it's like, oh, it's not good if. No, like very clearly no. Do we want it? Absolutely, right? Those are completely different things. Do we want to help these patients more? Do we want ourselves or someone else to cure epilepsy? Absolutely. That's why we're doing what we do. But then we need to appreciate as well that this result we have, if replicated as we expect to replicate plus, is phenomenal for these patients. And yes, the expectation is that it's longer, it's more time to respond, is more time to get to like levels of concentrations that one would expect to be therapeutic, and patients just have less seizures. The median number, of course, gets a smaller number. Everyone gets happy, and we move on. But the ultimate goal of this drug is to be widely used. And that is one step towards widely using, not the final step towards that.
Okay. Marsha, would love to kind of think about Power 1. One of the things that on Monday was a lot of analysts, including myself, asked around timing. But then I stepped back and started doing the math on my head and saying, okay, let's say you do finish enrollment today, right? And it's a 12-week study. So by the time that your data could be done, will be sort of middle-ish of December, which then would mean the earliest, like, would you want to put out data in the last 2 weeks of December? Probably not great for anybody. So I guess, can I say that, is it fair to say that your hesitation to answer exactly pinpointing the timing of Power 1 is just that internal, you know what, if everything goes perfect, and it could be, things going to be done in mid-December, and that's also not a good time, so it could slip in 1Q. Is that fair to say that is sort of what is keeping you to just say, yes, guys, the data is coming, I don't know, December XYZ? Yes, yeah. No, just check. Is that, so I guess that is what's driving your hesitation and fear. Okay.
Absolutely.
And I think you're going to announce enrollment completion, right? So then everybody can do their math.
That is
and you feel very comfortable that very much the enrollment completion is very near term, and you feel good about it. So nothing has changed. Yeah. So we can.
Yes. Since we're doing the math, let's do some math here as well.
Yeah.
Right? So there were a little bit shy of 20 sites that were contributing to Radiance. Right? And we see what happened, right? We gave them the opportunity to enroll more. They didn't enroll 1 or 2. Like, we're talking about having to tell people, don't enroll more patients on Radiance because we have too many. It's not a different problem with power. It's the same problem. I'm calling the fact that I'm calling that a problem is so oxymoronic, right? Because it's really not an issue in terms of enrollment whatsoever. It is just a very long process, right, for these patients. It's like 4 to 8 weeks, the screening. And so any patient that entered that period, it's like, it takes a very long time. I think we learned a lot about how to screen these patients efficiently, and the sites being phenomenal on helping with that, but it still takes several weeks. I think that's the uncertainty I would call versus fear on the final date of all of this.
Okay. So just a confirmation question from a client coming in. Can you confirm if you enrolled more than 50% of Power 1 patients?
that would be a material disclosure on this call, but
Okay.
you can do the math there. I think
Okay.
it would be pretty obvious.
Okay. Got it. Um, Next topic is going to be on, I think a lot of investors looked at the open label data and just argued the bears, well, it's open label, patients knew they were in a drug, so maybe the treatment effect was exaggerated in some way. I think that if you do look at the Xenon OLE data, it really actually provides proof that open label treatment response versus being in a placebo-controlled study won't matter. Could you walk investors through that data? Because I think it's very telling in my view.
Yeah, no, I think you're right? It's a good recent example. So I think that's why there are other examples in the past as well that show the same phenomenon, right? Maybe it is really because in our minds there is this embedded notion that people are just going to behave differently, counting their seizures if they know versus they don't know, something like that, which there's no real evidence, right? I think when there is no evidence, people go into the universe of opinions, which is never productive in science. Uh, but we do have like the Extol extension. It's published now. It's being shown in multiple posters multiple times. And I think it's pretty obvious, right? It's like you see the response, like you look into the switch on placebo, you look into the switch on the other dose arms, the understanding of what happened. That is, of course, is very difficult to remove the survival bias when you get to one point. So in a sense, there's an exaggeration there because of that survival bias, right? They have been exposed to something. Maybe the point I heard, and I haven't heard much of that, but is you can't just move forwards on anything in life and ignore that the baseline changes, right? So the baseline is not the baseline at day zero, day one. Baseline is the baseline at day like 56, at 8 weeks. And when you look into that, uh, there is no evidence whatsoever on that data set or in any other data sets, to be honest, that there is any difference between treating a patient in a double blind or on an open label fashion, even when there is full knowledge of the drug, as that was the case there, and the trials being blinded on amplification. So I think that's bogus. There are bare theses and there are bogus theses. This is a bogus thesis.
Okay. And Marcio, what did you guys assume for the placebo response to be in the Power One study?
Yeah. So go back to when we don't have like a base rate ourselves, we need to go back and ask what happened to go to the same exact trials we discussed before, right? To define like effect or to define time to effect or whatever we want to define. You got to ask trials that were run similarly, meaning
Mhm.
pull from the same pool, ideally contemporaneously, but there isn't really one fully contemporaneous to this, right? But there is one that is the closest, and I would say the Neurocrine NAV 1.6 is the closest of all of them, from both the type of patients, the type of sites, and the overall overall design. And then you have, of course, Xenon and cenobamate studies and so on and so forth. When you look collectively on that, the numbers go from like a +5, meaning patients go worse on placebo, to like a -18. So we conservatively think 20% is a reasonable number.
Okay. And Marcia, when you looked at other studies, does the duration of extension matter? Like when you go from week 8 to week 12? Like, is there a deepening that occurs that could help us also think about the translation from radiant into power?
Yeah, that is very clearly, and of course depends on the drug, right? So drugs that tap out very quickly, but it's very clear it does get better. I think the phenomena is Steve. It was if it was in the call, he would say it's a world phenomena. Less seizures lead to less seizures, and that's why we see this over time. So if patients have a benefits, they reduce. On trials that have no benefits, there is no change because again, there's no benefits. But on the case of having benefits, you do see a deepening. That's how we model. That's how we're looking into this. So we conservatively modeled about like 55%. That's public. That is in the protocol
Mm-hmm.
for power, and about 20% placebo. That is more than plenty of power to be positive. But obviously, for all the reasons we just discussed, I think that is on both those metrics, there is a space to move on the proper direction.
Okay. Is your when you look at the Radiant and the Power One population and background meds, it seems like maybe your baseline seizures can end up the same, but is there reason to believe that background therapies could be different between the two studies? Like how predictable is the two studies to one another, I guess?
Incredibly similar. And the vast majority of patients on Radiant would have enrolled on Power One, if that was the choice that was put in front of them. So that there was no reason to believe that those patients would be any different.
Okay, that's helpful. That helps. And and there is significant overlap between the sites between the two studies as well?
Yeah, there is a good overlap. I would say one of the things we learn, and I think it's kind of obvious in a sense. In retrospect, everything in life is obvious, but that like bigger sites, they just have a bigger machine to recruit and to screen, and from a quality and speed perspective, it's just easier in general. Bigger meaning like bigger available pool, not necessarily size, and then this quote unquote smaller sites, they just wouldn't be able to contribute to Power One. So we made a very deliberate choice to focus on some of those bigger sites. So the overlap is not perfect, but it's very high in the US. The other decision we made is there was really not a lot more patients in Australia that would be able to participate. Australia made a good contribution to Radiant, but it was just not available in a lot more what I'm going to call hyper-refractory patients there as well that are on the sites. So not having Australia, it's in Europe, United States, Canada as well. And so I would say Europe, North America, and South America is the overall makeup for Power One. And we expect to be identical, if anything. Virtually every site on Power One right now wants and likely will be selected to continue Power Two. So it's going to be a very nice overlap as well.
And then Marcio, in the Power One, you have 20 mg dose group and 30 mg dose group. The powering that you refer to, the 50% versus 20% placebo, was that for the assumption for the 30 or on a blended basis for both of the dose groups? So I guess what is the assumption based on the highest dose? And should we expect, since PK is linear, that we could actually therefore expect the dose response between 20 versus 30?
Yeah, so it's actually 20 and 30, right? So every patient's go through both of the dose. The effect is expected throughout the study on the 12 weeks, 6 weeks at 20, 6 weeks at 30. 20 doses, maybe you already got there, but we fully expect that to be fairly effective. So we're not really expecting a major difference there. And then obviously taking home with the last 6 weeks with 30.
And
okay.
And then since we're on that, and now that PK is like, what would you expect then the 40 mg dose group to do?
Yeah, you can do this one of many ways, right? You can do this the most caveat way, and adds relatively small benefits there. There's no small benefit here. You add 5 to 10% more. It's massive. Or I think you can just expect that it's going to be somewhat more linear. And then obviously we are on numbers like the ones you're quoting at the beginning of the call. I think one way or another, we do have an expectation that this would create even bigger chance for higher benefits. I cannot hear you. Yes.
Um, um, they're saying the question is for there is not to be a dose response between 20 and 30. I guess they're wondering why is there a dose response between 30 and 40?
Yeah. No, it's like, and I don't believe that that's what I said, right? What I said
Mm-hmm.
is that is a multiple components of the response here. So one is the dose you start, the concentration you
Mm-hmm.
get. The other is your time you stay on that dose and on the following dose.
Mm-hmm.
So what I said was we do expect very good response at 20. When I go back to the pop PK, when I go back to the exposures we
Mm-hmm.
had that would be equivalent to 20, because there's always a range,
Mm-hmm.
those were very good response. And then you bring them in to not only maximize that response for 6 weeks, but also go for 6 more weeks at full on dose. Those are not like differently from baseline
Yeah.
or term extensions. You don't have to reset at the week 6, right? They are already at a given level that is pretty high, that is much higher than a week 1. And then you are adding something to an even higher level. And that's where those models take into consideration.
Marcio, remind me, how are you calculating um, seizure reduction in Power One, like the time interval, and then
Yeah.
also the seizure free, and how does that compare to other phase 2b/phase 3 studies?
Yeah. So the two different methods there, or two different types of answers for the two parts of the question. So the way seizure reduction is calculated tends to be fairly similar across studies. And it's basically a rate per day multiplied by 28. That's what it really is. We talk per 28 days, but it's really per day times 28. And because most patients go to 28 days and they have very high compliance, end up being the same number, but that's how it's done. That is in a study with 12 weeks, it's the entire 12 weeks, but you express as 28 days. So that's how we expect to show the number here, non-controversial. Then when you look into what one could call seizure-free, then it really depends on a number of factors, right? You look into virtually every study that is being published in epilepsy, and it is when did we expect to reach steady states for this drug, and then we can count from there, or we can count from like after this first disturbance of the system happens in the first few weeks. So you're looking to cenobamate, for example, which is a lot of people quotes like a very high number of seizure from them. The entire first 6 weeks, right? There was an 18-week study. The titration can no longer be the one that was done there. As you know, that titration is not in the label in the US or elsewhere, but originally was. So 6 weeks, the data was completely removed, like literally completely removed. And then all the response, not only the seizure, the 100%, that would be seizure freedom as you call, but all the other response were calculated based on the last 12 weeks.
Mm-hmm.
I think that's actually fair for that drug. And you see that on other studies on clinicaltrials.gov as well, or the publication in general. I think the question we asked ourselves is there are kind of three major components here, right, for seizure freedom from radiance, and we're going to be looking the same for Power One. One is at the time these patients got to stabilize on the drug, like around 2 weeks to 3 weeks here, what happens to their seizures moving forwards. And that rates we showed for radiant is like 22% or so on the last 4 weeks. Then the second question is, was that only on the last 4 weeks? Because that is a very important. So we go back, and it was not. The rates of seizure resolution, or 100%, whatever you want to call, was double digit throughout radiance, right? Now, we really believe that you gotta get the data out for the most important, for the ultimate user of the data, that is the physician, and that last 4 weeks are quite important, right? And obviously the entire study as well. So if I pick the entire study, the first period, the second period, and by period is 4 weeks, they're all double digits. They're all more than 2 times
Mm-hmm.
what is the rate on other studies that were done. They're incredible, if you want to ask my opinion about that. But for Power one, we expect the same. Like
Mhm.
the last 6 weeks is a very important time to measure that, but the entire study is an important time to measure that as well, right? The important part is to give a very good benefit for those patients, and we have no doubts that that's the case here.
Okay. Marcia, what do you fast forward? We see the Power One result. What do you need to see from Power One in terms of dose selection and patient criteria to kind of fine tune your
Yeah.
plans for Power Three that you unveiled on Monday?
Yeah, no, Power Three, it was, as we talked to a lot of people, so I'm going to concentrate that if that's okay, because we haven't talked about Power Three. Then you're like, okay, this drug is very competitive on these markets. That is what the rotating 30, right? It's the people who are like always switching drugs. Is there space for everyone in the markets? Like you could have 10 drugs, they all do well. They all would be billion-dollar drugs for that population. And I think we checked the box and we're like, okay, this can do really well here. Uh, but when you look into the overall safety, for example, in like 20-25% less patients are having any side effects. When you have the overall efficacy on the potential to go to a higher dose, potential higher response. And then other things, right? The first question I get from physicians is none that we're discussing today is like, is this teratogenic? Because there are multiple drugs that are, and the answer
Mhm.
is absolutely not. Does this have any meaningful DDIs? And the answer is not, because that's what a lot of them care about. We know epilepsy primarily affects females, right? A lot of reproductive age. Like, does it interfere meaningfully or at all with oral contraceptive medications? The answer is not. And when you lined all of those things, I was like, and when you give this drug, like in combination, it's fairly manageable side effects, it's good response, and likely going to be even better if you reduce the numbers and so on. The place for this drug is to be earlier and earlier in the treatments, the ultimate place, not the only place, right? We're going from single digits $1 billion to potentially even double as we go to this market. So that's what Power 3 is aspiring to show, right? What we're planning there is like there has not been a drug in modern history of epilepsy treatments that had the confidence to do that because no one so far had that entire profile that allowed it to do. Uh, so what you're looking to Power 3 is, of course, we're still finalizing the design and there's like much water to go under that bridge, uh, but it's really to go with what we would expect, for example, 40 milligrams. And then from that point on, see the response. So we expect high response. And because we're switched to monotherapy, really not a lot of liability associated with that. So that would be quite complementary. You don't need that. We don't intend to have that done at the time that we potentially would be filing an NDA, but that would be a very nice complement to increase like overall perception on the market, number one, but then shortly thereafter to
Mhm.
file as an sNDA.
Okay. Couple questions on sort of the radiant data that's coming in 4Q, right? The generalized and maybe the additional patients. I guess based on just the timing, we would expect the additional radiant data is in 4Q, but probably ahead of Power One, right? That's fair to say.
About the
Um,
same, but yes, yeah.
yeah, okay. Second question is people are just trying to do the math, so they're wondering how many, it sounded like when we were on that topic at the beginning of the call, you said few patients have now finished week 3 and 4 to be cut. I guess what people are trying to figure out is how many additional, focal onset could we get?
Yeah,
And
yeah,
we could get a few generalized as well. So
yeah,
I
yeah.
don't know.
So the 61 total minus
Yeah.
37 that already show the data, they're all focal,
Okay.
right?
Yeah.
They are all well underway in the study.
Yeah.
Like the vast majority of them are towards the
Mm-hmm.
end of the study going to be finishing
Yeah.
relatively. So we're very good there. Uh, there are few patients that were done with screening, haven't dosed yet. We didn't count that on the 61,
Yeah.
both focal and generalized. So forward to guess, right now, we're going to have a little bit higher than 61 on focal and then all the generalized. We didn't tell you how many generalized we had.
Yeah.
But then you're going to have that generalized cohort as well that you haven't seen anything about it.
Yeah.
Now, the premise for generalized is that the drug would not work.
Yeah.
We're talking about a premise here that the drug would work, right? But if you go,
Mm-hmm.
common sense would say shouldn't expect much from this. Like that is not other drugs
Mm-hmm.
that one could call similar. They're very dissimilar, but one
Mm-hmm.
no. So and what I'm telling you right now is like so far that's not the case.
Yeah.
We're actually
Okay.
pretty positive about the impact on generalized, and you're going to see by the end of the year whether or not that's confirmed.
Got it. But just to make sure is like you're not enrolling more patients beyond those 61 on focal. You're done with focal. Anybody who's coming into focal is going to obviously go to power one. There's no reason of more radiant. But the nice part is 61 minus 37, that gives you 24 patients that haven't finished the total treatment of duration for which we could potentially see data. And then another 14, right? 675 minus 14, so 14 patients in generalized that we could get,
You might
right?
have one or two more in focal that were in this mix
Yeah,
that had not finished screening at the
yeah.
time of disclose, but it's not going to be anything materially different.
Okay, but that's and you haven't disclosed how many of those 24 that's in the queue are on background cenobamate or any other background therapies. I
Yeah,
don't know
so
if you
the
color.
rate was fairly
Yeah,
consistent throughout,
yeah,
and we did talk about the 30%
yeah.
on the first patients. The second cohort is like
Mm-hmm.
smaller. The rates is similar. It's a little bit numerically a little bit higher
Mm-hmm.
as a percent, but it's on the 30s as well.
Okay, that's helpful. Um, and I just want to make sure there's like a lot of questions coming in that because I have a long list of mine.
We have
Also,
over 3 minutes.
since we love discontinuation there, the question is asking, does that mean the discontinuation rate should not change in the 14 out of 61 and 6 out of 61 dose reduced focal patients?
Yeah, that's absolutely the intent, and that's what we are seeing so far.
Okay, good. That's helpful. So I guess if I had to like think about sort of what we learned today that I think didn't get appreciated was like the checklist of we're going to get potentially 24 more patient data, 14 generalized patients later in the year. And we should actually, since we're on that topic, what is your thought on as you add more patients in focal in the new generalized, how do you think what do you want to message to the street what we should see in 4Q, both
Yeah,
in both population?
one more patients always refine the estimates, right? And
Yeah.
estimate's going to be more precise at the end. Of course, we monitor these patients throughout the
Mm-hmm.
study. I would say, like, if these patients are behaving any differently than the first cohort of patients, I would say it.
Yeah.
And so that's not the case. So I think we should expect something very similar to what we're seeing here. Of course, these patients all have to finish, and until they
Mm-hmm.
finish, they haven't.
Yeah.
So no formal statement about what's going to happen, but more like a forward looking in terms of what we expect. But nothing problematic. The general background and the general like seizure counts, they're very, very similar to the first.
Okay. So Marcia, now I'm going to run a checklist by you really quickly based on what I learned from this call. If I miss something, you add it. If I misspecified, you also explain.
Yeah, rapid
Okay.
fire.
All right. Let's start. Radiant 1, right? We're going to get more data, potentially 24 patients and 14 generalized. It's going to similar treatment response you expect, but no surprises. On 4Q, we also learned timing of power 1 could be pushed into early 1Q because of the dynamics of just in case getting the data ready in December. That's why you're being quite around it and not saying, yes, it's on track for December XYZ because of those challenge. Third point is we learned that based on your PK analysis that the PK is very linear, both across AUC and Cmax, which therefore should make you very comfortable around deepening of a response when you go to the 40 mg dose group in your power 2 study. You also talked about that your coefficient of variability is also very consistent. Then we went and you also noted that your exposures has no effect on efficacy and no effect on discontinuation. You also talked about, yeah,
That is not correct. Yeah, so no effect on discontinuation or side effects, but an effect on.
yes, on efficacy. That's right. That's what I meant. Yes. On discontinuation, you noted most of them occurred between week 1 and week 3. You also talked about the imputation of those into your efficacy analysis. And you also talked about on a blinded basis of power 1, which you assume 20% to be the case, you don't see it, you see it to be, you said something along the lines substantially lower. Okay. I heard that. So that's good. You talked about power 1 being powered for 50% and 20% placebo responses. We talked about the Xenon data, that if you look into that, and anybody who's on this call wants to send that to me, feel free, or needs the publication, I'll send it to you, because I think it's a very important analysis to figure out the chain, that it doesn't inflate the treatment response, right? So that's another takeaway. And then we talked about cenobamate patients were highly treated. 30% that were treated were in the 300 mg dose group, which is a very high population, high dose, which most physicians, based on my channel checks, does not feel comfortable. That tells you these are really well-experienced docs. And then on discontinuation, under your breath, you said something that some of those are run by few centers rather than generally seen. So I feel like we tackled a lot. Was there something we missed that
Hard to
you feel
believe we
like?
tackle all of that in an hour. Yes.
Yes. Okay. All right. So that was super helpful. I think, we're very much looking forward to what is coming at the scientific conference here at what are we going to see
So a lot
last
more
question.
details about all these questions you asked. I think what is super interesting as well, I'm very interested on, is there are different seizure types.
Yeah.
I think when we look into the different seizure types, it tells a further story about the
Yeah.
drug, right? And we're going to be showing that data as well. I think we are all very excited. The presenting investigators very excited about it. So I'm not sure if I'm going to see everyone in Portugal
Yeah.
but I hope so. I'm going to be there, so please
Yeah.
join me. But if not, we'll share the posters. We always put on the resource page of our website.
Great. Well, Marcio, I do want to congratulate you on the data. I think a lot of the supporters of the company see the data. I think this fireside chat was helpful to really dig into some of these topics. So again, thank you. I know you're extremely busy, and thank you for all of our audience. Obviously, many of you are buried in earnings today. So thank you for spending time with us.
Thank you so much, Yaz. Appreciate the invite.
Thank you so much.
A lot of fun. Thank you.
Thanks.